everyone, and welcome, like I mentioned to some of you already earlier, Session 10, which is our final session of this Medi-Cal Academy. Today, we'll be talking about the different data elements that we should have in mind to help support any documentation that we may be doing for different systems that we may be utilizing going forward, especially when it comes to tracking different funding sources and meeting different funder requirements for data that we need to make sure we're collecting. And today is May 17th, yes. So what is CSH? Really quickly, CSH is a nonprofit CDFI, and you may have heard this term before, but essentially it means that we provide lending for affordable housing that's being developed in various communities. We're a national nonprofit, but we do have regional presence throughout the United States, including in your state in California. And we do a lot of work related to supporting our most vulnerable community members to advance solutions that contribute to housing, right? Which is a primary need we know for the folks that we're serving. And that is why we are part of this Medi-Cal Academy experience. If you haven't met me yet, my name is Ambrosia Crump. I use she, her pronouns. I'm in your time zone, but not in your community. I'm in Las Vegas, Nevada, but on our national consulting team. And I'll turn it over to Cheryl to introduce herself here quickly.
Thanks, Ambrosia. It's good to see all of you again. Welcome to our final session. Session 10 for the Medi-Cal Academy. I'm Cheryl Winter. I use she, her pronouns, and I'll be one of your trainers today.
Thank you. So where are we and what content we have covered in this experience here? As you can see, different audiences were invited to different topical sessions, depending on whether or not you'd be contracting with a managed care plan or maybe subcontracting with another provider or with the state itself or county itself. Sorry, not state, county itself. Right now, we are on session 17, which is the EHR elements that support any documentation that may be relevant to track, again, for Medi-Cal community supports, as well as some considerations for other funding sources and the tracking requirements that you may have for those different funders. So for this session, we want to see providers here, right? We also are inviting our managed care plans and any COC and county staff to this session. So if you are thinking, is it appropriate for someone to join, send them the link and hopefully they can sign on and be part of this experience today. If not, as you saw earlier, we are recording the session for future viewing and review. So what are some of our learning objectives for today? We will be looking at understanding the key differences between different data systems, and you'll see some acronyms here, but don't worry, we'll go in and define these different terms like an EHR versus an IHE versus an HMIS. Some we're familiar with, some we may not be so familiar with. We'll look at the key data elements to track for documentation and quality improvement, especially considering how we can save time and making sure we're capturing some of this data up front so we don't have to double back and figure out what we needed for a funder or for our program. And that kind of goes into some tips for data elements to help track your staff time and by funding resource to figure out which source should be paying for which activity that your staff member is providing or service that they are delivering. We will be looking at identifying some required data fields that are very specific to the housing related community supports reporting as dictated by the state from information that we learned from them. So we'll be doing that today. And without further ado, I'll be turning it over to Cheryl Winter, who will be getting us started here.
Thanks, Ambrosia. Please let me know if at any point you have audio issues with my microphone, so feel free to put that in the chat. Today's session, I'm really excited about it. There's a lot to cover, and I would like for you to approach the session thinking about what are you gathering today that you will need additional technical assistance on in the future. There are so many opportunities now where grant funders and the state are looking to fund technical assistance. And the more specific you can be on what your technical assistance needs are, the better. So any questions that come up today that we are not able to answer, or that might be very specific to your agency and your agency type and the depth and breadth of services you are offering, please jot those down so that you can then bring those to any technical assistance requests, whether through the TA marketplace or through another technical assistance opportunity. I'm going to kick us off just introducing the data systems that I'll that we've received most questions about, and that most of you are interfacing with in one way or another. I'm going to provide a little bit of a summary of what each system typically does or how they can be best used. And then we're going to dig into the data elements that you may use at your agency, fields that you may want to add into your forms, or data that you'll want to track for documentation, for quality improvement, and some of the new funder requirements of data you'll be receiving if you hold a community supports contract, or data you'll be asked to share if you hold a community supports contract. For any of you that also have enhanced care management contracts with managed care plans, there are also a lot of data elements and file sharing, both files you'll be receiving and files you'll be sharing to the managed care plans. So we have links to some of that guidance, but I'd encourage you to, again, list out what questions you have related to ECM and include that in any TA requests for future TA opportunities. So let's dig in. Okay, so these are the 4 types of systems that I'm going to touch on before we delve into the data elements in particular. So we're going to talk a little bit about what HMIS systems in general are capable of. Every system varies based on what your COC has selected and has paid for, and the add-ons that they may or may not have incorporated or given you access to. So at this point, we'll be talking broadly about HMIS systems. There are multiple vendors across the state of California, but there are a few that many of the counties or COCs are using. And so I have been able to speak with some of those vendors that represent most of the state so that we could double check some of this around what it's capable of or what add-ons are possible. I'll touch on case management software briefly because several of you mentioned that you do use case management software right now. And we'll talk a little bit about how that might differ from using an electronic health record. An older term for electronic health records are electronic medical records, so you might have heard that as well. And then lastly, we'll dig into a little bit about health information exchanges and community information exchanges with some examples of how they're used in the state. All right, feel free to put questions in the chat, and then if questions pile up, Ambrose, I'll ask you to let me know so I can pause. But we'll get started just talking about definitions. This is to level set since we have agencies with all different experiences. So for HMIS, each homeless continuum of care is responsible for selecting a homeless management information system. That's a software solution that complies with the federal government Housing and Urban Development, or HUD's, data collection, management, and reporting standards. So there are vendors that create these local technology systems, and the COC then is able to select what types of data access its agencies have access to, if you'll have agency administrators or data managers at each agency or not, and then what types of data is visible to all of the different participating providers. It is really just a data system that is for housing and service provision related to people experiencing homelessness and people at risk of homelessness. But there are programs that are funded from the Department of Health and Human Services, from SAMHSA, which is the Substance Abuse and Mental Health Services Administration, as well as from HUD and from the Veterans Administration. So many different programs use HMIS. An electronic health record system, simply put, is a record of any health-related information that can be created, gathered, managed. It can be something that is within only one agency. That's a software that's purchased, which could be something that's downloaded and managed at the agency level. It could also be something that's cloud-based. It typically has functions to let information flow between the agency and those that are paying for services, so it's funders, any labs, clinicians, hospitals, specialists. It could have features where you can share information back and forth with patients as well. And so there are lots of different ways that other applications or other softwares can be integrated into electronic health records. So this is often, I'd say, the most robust in terms of what an individual agency would have for tracking and managing individual client data, and the ability to integrate with your finance systems and accounting systems and QuickBooks and your calendar and email systems and lots of different integrations. So we'll get into what is possible for electronic health record systems. And I will say that there are some systems that massive agencies prefer, like giant hospital systems serving tens of thousands of people. And then there are some other smaller EHR systems that might be better for an agency that's serving, a few hundred to a few thousand people. And then case management systems are software applications that are typically designed for nonprofit organizations that are grant funded. It can also be a system used by social workers or therapists to manage their therapy notes, track case information. Oftentimes they have management systems to track donors, fundraising, your sort of contact tracking. Some have applications that are to support board development, accessing and recording client needs. Some also have evidence-based practice care planning or care pathways worked in to sort of guide the clinician through, if this issue comes up, this is how you would sort of case manage someone through this situation. These are typical resources to follow. Electronic health records often also have applications that you can add on that are care pathway applications. So if you are serving a lot of people that have multiple different social service needs, and you want sort of a guide that is based on evidence-based practices on what the typical care pathways and referral mechanisms might be, those two systems do typically have those add-ons. Some case management software are designed for tracking program outcomes, and others are not. So some really are around case notes, and others can allow you to pull reports and track progress over time and create dashboards. I would say that case management software in general has contact management systems and donor management systems, but may not be set up. They may not all be set up to do things like submitting claims to CMS. Okay, so health information exchanges and community information exchanges, when I think about these two, they are portals that essentially allow multiple providers. In a community information exchange, it's often much more broad than just healthcare providers. So it could be any other social service agencies to enter in data and share data across the platform. And it can be done in multiple ways. So for health information exchanges, it typically is only related to patients' medical information. It's intended on helping with referrals, accelerating the speed in which someone, a referral is made and received and services are authorized. And there are multiple ways that you'll see these information exchanges happening. Some are direct exchanges where you're actually able to send and receive information securely and electronically between providers, but there's no access to information if someone doesn't initiate it. So unless I say, Ambrosia, we have a common client, let me send you this information, and Ambrosia goes in and logs on and then receives that information, she wouldn't be able to go log in and access it without me having initiated that transfer. In a query-based exchange, it does allow providers to find and request information on patients from other providers. That's for things that are more unplanned care. So you can see then patients that you may have in common if you both have authorization from that patient to view their member information. And then The consumer mediated exchange is really where patients can also log in, and they can control how their health information is used among providers. So it's not just that a provider tracks that they signed a release of information, but at any point the patient can go into that portal and take away that ROI. So these are 3 examples that you'll hear about, and some health information exchanges across the state are looking into how they can build out and collaborate with community-based providers who are offering community support so that you can then share information. And this is something, if you're an enhanced care management contracted provider, you'll want to learn about what health information exchanges or community information exchanges are happening in your area. Whereas a health information exchange is primarily healthcare providers, then a CIE, community information exchange, is really a multidisciplinary network. So they, as members, as they join this network, they can decide to either participate fully and comply with the, shared language, shared data systems, and share information to the entire network, or they can choose to participate by simply receiving referrals. So an example of this type of exchange is in San Diego. And so I've included links to both Lanes in Los Angeles and the CIE in San Diego in case you are interested in understanding more about how you could better coordinate with healthcare providers and other community-based providers in your region. Next, I'm going to dig into some of the possibilities that we are seeing right now for HMIS. And this is because, as more and more homeless service providers are becoming community supports providers, there are a lot of questions coming up about what is possible in terms of pulling reports, getting data to then submit invoices, having documentation and not wanting to duplicate entry into HMIS and another system. So if you are only using HMIS right now, I want to highlight some of these things that are possible, but it may require conversations with your COC and the leads that are managing HMIS, or it may even require that COC to then build out an agency manager role so that you can also have agency access to be able to pull reports, view databases. So there are some add-ons to what most HMIS vendors are able to do that could support you in building out your community supports data in HMIS. So in HMIS, there is the option where your COC could work with their vendor to build out new templates. That could be your assessment forms, that could be your service plans or progress notes, and any fields that are added in to your HMIS system that are, any data fields. So first name, last name, client identification number, managed care plan that is serving this individual. Those data fields could then be pulled into other forms. So as you build out new forms and templates in HMIS, it can actually start to create data fields that then can auto-populate into other forms. So this could save your case manager's time and documentation. It could make it easier to then be able to pull, Excel reports for invoicing. And if you have the data analysis add-on turned on with your COC's HMIS, then you could also create individual user dashboards around progress or agency dashboards around progress. Any questions right now just about what's possible in HMIS or some of the items listed on this slide? One thing I learned is that this may vary by vendors, but some of the HMIS vendors did say that they can accept signatures. So you could have a case manager when they're hired. You could have a screen where they do their digital signature on the mouse pad. And then once it's saved, every progress note that they create or every service plan that they create, they can, it will automatically include their signature when they hit submit. So there are ways that you can be compliant with what's required with Medi-Cal and Medicaid and use HMIS for that. I'll also say, though, one big thing to note for HMIS is that you'll need to be very careful with the HIPAA privacy and security regulations. And if you are going to be using HMIS for your data related to community supports, then you'll want to have a business associates agreement in place with your COC to ensure that the COC is operating according to the HIPAA privacy and security regulations. The majority of HMIS platforms, the systems in California have the security features in place to be HIPAA compliant security wise, but those vendors cannot control if the users are being compliant with how they are sharing the data and who they are giving access to view certain programs. So this is where you would need to work with your COC to ensure that if you create a program or a department within HMIS that is just for community supports, that is visible only to your agency and only to select individuals within your agency. And you'd want to have that business associates agreement in place. There are 3 types of users that are most common in HMIS systems. So there's, the staff that are entering the data only. Then you have agency manager roles, and not all COCs have this function turned on right now. So again, this is another conversation to have with your COC. Do you have that role? Is it possible? Is that an add-on that has a cost? If so, what is the cost? Because as there are grants available right now, you'll want to be thinking, does it make sense to build out HMIS, or does it make sense to purchase an electronic health record? What makes sense for your agency and for your COC? And then the system administrator access role is held by the COC. And as I mentioned earlier, there are add-ons where you could create dashboards for end users and for agency managers, which may be really helpful when you're working on quality improvement initiatives. I'm going to pause and look at the chat if there are any questions. Yes, I will touch on electronic health records to support billing for CalAID. Yes, Lakeisha, thanks. Okay. So here is where electronic health records excel. The ability to send data through a secure platform that is not via email across to other providers, to make referrals, to receive information about someone's medical history. All of these pieces in that first bullet point is going to be really important if you're an enhanced care management provider. You'll be receiving data in member information files that include lots of these protected health information areas, like someone's medical history, diagnoses, medications, lab results, and you'll need to be having a place to receive that data and store it securely. An electronic health record, you could import those member information files into an electronic health record and store that, and it will help you to then track, which providers have you made referrals to? Is there information that needs to be shared for patient care and coordination with those providers that you're making referrals to? Oh, thank you for explaining the acronyms. I appreciate that, Ambrosia. And as I said earlier, electronic health records also excel at having sometimes built in, and sometimes these are add-ons that you can, pay specifically for, but they often have evidence-based tools that can support for your service plans, for your progress notes, and these care pathways sort of touch points that help to say, okay, you identified that someone has a housing need. Do they have their identification? Yes or no? These care pathways sort of walk you through. Have they been connected to a primary care provider? Do you want to go on that pathway and start that? So for case managers that are new to thinking about multiple different aspects of a person's wellness, those care pathways and evidence-based tools can be really helpful. It also is really helpful in automating workflow. So you can then, as one form is completed, it can trigger and notify other users that it is now time for them to review something or to do a task. So you can automate some of that review of your documentation for your quality improvement. And also you can automate and ensure that you have reminders set up for things like, this person is due for a service plan. This person hasn't been visited in 30 days. Maybe we want a notification so that we're ensuring our quality standards are being met. So some of those workflow issues and notifications can be really helpful and can be created in electronic health records. And then electronic health records have a lot more available in terms of the applications that they can integrate with. So your billing software and accounting software and office systems, and integrating with your HIEs in your community. They usually offer multiple secure information sharing options. So it could be that they then come with an email encryption application, or that they're able to submit files, through a cloud-based portal. Electronic health records really vary in terms of cost, and they will all say in their marketing that they can do everything you want. And if you are looking at purchasing an electronic health record, it's important that you start asking about, can you test it beforehand? Can you test it for 30 days? Can they, give you time to work in it and see if you can build out the forms and templates and tools that you need, and if it really can support your workflow? Because, these are big companies that have sales representatives that are working to get your business, and they may be selling you a product that is best for a massive hospital system or a huge primary care network, but you may not need something that sophisticated or expensive. And it'll be really important that you are able to test it out first. The other, I'd say, benefit, or what an electronic health record excels at, is that it is administered at your agency level. So if you have agency staff capacity who have the IT knowledge and the time to build out your reports, then this might be an excellent option for you. If you have funding for a consultant to support in building out your electronic health record, this could be a great option for you. It really depends on how much control and time you have, how much control you'll want to have over all of the data that you're managing, versus would a COC be helping you to create those forms? Or do you not have the staff time, and this is something that you'd want to explore with a TA provider to even determine which and if any electronic health record is what you want to go for? I'm going to open it up for questions again. Any questions about electronic health records or versus doing something in HMIS? We're going to get into the new data elements next. So this will give you a sense of, as you're thinking about what data you currently collect, what you currently ask about, how you collect that information, who is the person that's in charge of collecting it, and where do they enter it into right now. There are some new data elements for community supports providers that you will be having access to, that will be shared with you every other week by managed care plans. And so you'll need to have a plan for where you store that information and how you store it securely. But then you'll also have expectations around data that you'll be sharing with plans monthly. So we'll go into that next. Okay, so first I'm going to talk a little bit about the data that will be coming into you. So these are reports that are being sent to providers. The first that I'm going to talk about is the community supports authorization file. There are several important links included in this slide deck, and we also include them at the very end in a resources slide. So I included the PDF of the slide deck in the invitation for today. And so I just want to make sure that you all have access to these links so that you can pull them up and download these tools. They are being updated by the Department of Healthcare Services. So some of these guides have been updated as recent as April 2023. So, what we're sharing now is relevant for right now, and this is the most up-to-date information. But I do want to make sure that you have saved the Enhanced Care Management and Community Supports homepage on the Department of Healthcare Services website so that, if anything changes or is updated further, you know where to go to find it. Okay, so the Community Supports Authorization Status File. This is something that was just updated in April. This is a file that managed care plans will send to the community supports provider. So whoever holds contracts with them, they'll send this to you every other week or every 10 days. There is a chance that the managed care plan has the right to work with you and talk with you about frequency. And if you say, until we have 10 or more people referred to us, you don't need to send it to us every other week. You can send it to us only as often as when someone's new. They may present to you an option for doing it less frequently, but if you have not had a conversation with them yet about this, then the expectation is that they will be sending this to you bi-weekly. I would look at the guidance that DHCS has put out because there are timelines for when they expect managed care plans to be compliant with sending you this information. In the guidance from the Department of Healthcare Services, DHCS, they explained that plans could be sending this to you in an Excel workbook, or if they agree upon another kind of file format with you, they could send it in another file format. Again, if you have a contract, please be sure to read your contract and see, have you agreed to anything that you weren't aware of in the contract that says differently than this? There are 33 data fields that the plans are required to share with you. There are 6 additional fields that are optional. So the data fields that are required include things like patient's first name and last name, the start date that they were authorized for a community support, which community supports were they authorized for, the client identification number, that is the Medi-Cal CIN, race and ethnicity. There are a number of data elements that the plans must share with you. And then there are some that are optional. Look at that optional list and check and see if any of those are data elements that you would really like to have so that if it would be helpful for your own quality improvement activities. And I'll talk in a minute about how these data elements could help with your own quality improvement activities. So managed care plans are strongly encouraged to establish processes. So they're not required, but they're strongly encouraged to make sure that providers have a way of acknowledging receipt for the file. So that could vary by managed care plan. In this updated guidance that came out in April, I put a quote here from the Department of Healthcare Services because they are listening to people's feedback. They're listening to new provider feedback about how you are navigating multiple managed care plans, requirements, and some of the differences. And so they released this guidance because they wanted to increase standardization. So they are making it clear to managed care plans that there are certain data elements you must be sharing, and you must be sharing it at this frequency because they have heard providers say, right now we're dealing with, multiple plans and they all do things differently. So I say that to encourage those of you that are contracting with multiple plans that, keep giving that feedback when you can. If there are any forums or webinars that the state is hosting, when you receive TA or grants, any avenues for giving feedback, it's being heard. And it may take time for those, for guidance to be updated, but this is one that is hopeful in that there is standardization now being required. Okay, so here is, of those 36 required data elements that you can look at in the guidance. But here are a few that I thought, if you're not already tracking this, then this is a great way to say you're receiving this Excel file. It's coming to you every other week, and it will include everyone that has been authorized and referred to you. So even if they were on the last report 2 weeks ago, they will again be on this next report 2 weeks later, along with whoever else is newly authorized. This is great because it means if you weren't able to get, your ducks in a row with integrating the data into your system now, that's okay. If in 6 months you get that file and you now are able to import it into an electronic health record or into HMIS, you'll be able to have these data fields and pull reports and set up notifications looking at, when did someone get authorized and when does the authorization end? So do you need to then set up a report where you're tracking, a month before authorizations end to start working on things, or 2 months before they end to start working on things? It will also include the Medi-Cal renewal due date, which is going to be critical for you to get paid. We know that right now the COVID public health emergency has ended. And so members now are going to have to renew their Medi-Cal eligibility again. It was paused for a while, so no one had to go through that process. And there is concern nationwide that some people will fall off of Medicaid or Medi-Cal access if they don't get the message that they have to renew it. So getting this date from the managed care plan for every person that's referred to you is going to be really important to determine how you can help the people you're working with stay enrolled in Medi-Cal, and in that, then stay enrolled in the community supports that you're providing. We talked some about quality improvement and ensuring that there's race equity in how we deliver services. So as managed care plans have to track and share member race and ethnicity with you, they're doing it through a code system that is included in the guidance. So a number of these things use codes. A number or a word that the state has decided that all plans will use the same thing. This might be different from how you're currently tracking it. You might not be using codes for some of this. And so thinking about how you'll take that data that comes in this Excel file and import it into your system. If you're not right now tracking race and ethnicity, this is a great way to start tracking it and to start looking at, are there differences in outcomes and how people are served, or in client satisfaction, or any other measures that you're right now looking at? Is it different by race and ethnicity? And what can you do then to address it? The last two things I'll mention here is that the plans will be sharing who the enhanced care management provider is, as well as the contact information for that enhanced care management provider. This is a provider you'll want to be coordinating with. So it will be very important for you to upload that information and have it, and make sure that your case managers have access to it. And then lastly, if you have contracts with multiple managed care plans, this last one, primary payer ID, is a way that if you're receiving files from 4 or 5 managed care plans and you're serving 1,000 people in community supports, let's say, that payer ID is going to be really important for you for any of your tracking, because that is going to be what tells you which managed care plan is right now serving that individual. I'm going to go now to talk about some of the data elements that you will want to include to be able to, if you don't right now have forms that include these data elements, you'll need to add these elements to forms if you're going to be providing community supports. And then, as I mentioned, for both electronic health records and for HMIS, any new field that you enter can then be turned into an automatically populating field in other forms. So if you have someone's name and client identification number in the file you receive from the managed care plan, and you import that and it becomes attached to someone's assessment, let's say, you can then have it linked and automatically populate into their service plan, into their progress note, into whatever you then pull, whatever template you've created for invoicing, so that a case manager is not having to worry about typing something perfectly correct, or they're one letter off or one number off and suddenly you're not getting paid. So I'm going to start with looking at progress notes. This should look familiar for those of you that were at our documentation session. So you'll see some of these are going to be codes. Some of them may require the date format to be changed. So you saw in the state date formats in the guidance is always month, date, year. So two places, and 4 places to write out a date. So like 12/22/2013, it would all be spelled out. If right now your dates are looking differently than that, that might be a conversation you have to have with whoever at your agency manages the data, and whoever at the COC manages things. Some of these are going to be narrative, and those are not fields then that you'd want to move into auto population. However, I would say if there are specific assessment needs or specific service plan goals that are often, common among clients, you may want to have drop downs available so that those could then auto populate. You could pull in a service plan goal to then be at the top of a progress note for someone to check the box and say, yes, I'm working on this goal today. There's a coding options guide that is also released by the Department of Healthcare Services that I want to be sure you all are aware of. This includes a number of different data elements that need to be included when you are invoicing for community supports or for enhanced care management, and what is shared between you and managed care plans. So I did not include all 4 of these tables on this slide. It would have been too much data, but you'll see that there are these 4 categories of data. So information about you, the provider, that you must have. And so it would be really wise to have some of that information as its own data field that then auto populates into your service plan, into your progress note, into your invoice, so that you're seeing that member information is consistent across all and doesn't have to be entered in manually or written. The service and billing information, you'll see there are a number of codes there. There are codes for if it's housing navigation and transition services. There's a separate code if you're billing for housing tenancy sustaining services. So check out those codes. And these are things that, as you're thinking about technical assistance and grant funding and building out your data software systems, you'll want to take a look at these codes and see how different it is than what you are currently tracking. Right now, managed care plans must allow providers to submit invoices as an Excel-based workbook, or they can offer you a form via a portal that they create. So I want to point that out and ask you to look at pages 10 and 11 of the coding options guide and the billing and invoicing guide pages 10 and 11 of the billing and invoicing guide, because it does give managed care plans a little bit of flexibility, but it always says that it needs to be in conversation with you. So we want to make sure that they are having those conversations with you. Here are some examples of data elements that you may have in a housing supports plan that you may be pulling from other data fields that are already existing. So as you get, where can we find the billing and invoicing guide? Great question, Jonathan. Thank you, Ambrosia. I'm going to close the chat so I don't get distracted, but I appreciate you answering those, Ambrosia. As you get some of this information, receiving it from the managed care plan, you'll want to be uploading it so that you have the most recent member information around authorization start and end dates, the client identification number. You should have your provider name written exactly as it's written in your contract with the managed care plan, case manager names, The start and end dates of the housing supports plans. This will be really important to have on all of your plans, but to have them as data fields that then can populate into your progress notes. So again, as you're building out your forms, think about which elements from one form can then automatically populate to another so you're not having to do double work. On your housing supports plan, you'll need to say if it's a housing supports plan for housing navigation and transition, or for, or if you're working on housing deposits, or if you're working on housing and tenancy sustaining services. When you are marking those, you can decide, are you going to use the codes that you'll use for invoicing and billing, or are you going to use plain language? Do you have the ability to then pull that plain language and convert it into a billing code? Do you have a staff member that does that manually? Do you have a system that does that? Thinking about what you already have in place will help you, and what you'll need for submitting claims will help you to think about how you'll then write out or what data fields you'll use for your housing supports plan. Next, I'm going to be talking about some of the data elements you might want to think about using for quality improvement. And when I was thinking about this slide, I was really thinking about if you're using either HMIS or an electronic health record, both typically offer you the opportunity to create dashboards where you can have a dashboard that shows sort of whatever key goals you have for a case manager, for a program, for a supervisor. You could, say this month we want to work on the amount of time it takes from us getting the referral to having our first visit with someone. So finding them, providing outreach, and having that first visit. Maybe that's something that you want to work on as a team. And so you want all of your case managers to see where you are currently and what your goal is. You can pull your existing data to then create these dashboards. And this might be an add-on, data analysis add-on for HMIS, but most electronic health records do allow you to build out dashboards, and most of the HMIS vendors do as well. You'll just have to work with your COC to determine if that's something that you already have added on, or if that's something that would, be an additional cost. So here are some of the dates and elements that you might want to be pulling to then be comparing and creating reports and dashboards. So you might want to be thinking about the speed of delivery and how long it takes from someone to be, referred to the managed care plan. And then once you get the authorization from the managed care plan, how long does it take until they move in? Are there system level issues that are in that make it take more time? Or are they issues that are related to you and your own providers and what you have control over? You might want to be thinking about tracking your quality assurance processes, like, are people completing their progress notes in a timely way? Are they waiting 2 weeks to write their note about what they did 2 weeks ago, or are they writing it the very next day or that evening? So as you begin to build out these data elements around the date that a note was written and the service date that it was provided, you can then start to create these dashboards for your team, and it'll make it much easier for you to have a snapshot of how things are going. One of the things that I've heard a little bit about is related to acuity levels. And so if you do have an assessment score from someone from their VI SPDAT, or if the managed care plan is sharing with you information about someone's diagnoses and their medical needs, you may want to then start to track the number of visits you're providing to people based on their acuity level, or the number of hours spent with people based on their acuity level, to start to understand, are you being paid the same rate for everyone regardless of the intensity of their service need, or do you need to negotiate for a rate that addresses that there might be differences in acuity levels of people being referred to you? It also can help you to look at just the distribution of clients in a caseload by case manager. So you can look and see, does Ambrosia, is she serving 15 people, but they all scored, having the highest score on VI stat, and also from this member information file shared from the managed care plan, they also all have complex and chronic conditions, whereas Cheryl's serving 15 people as well, and half of them are families, but they all scored lower on the VI SPDAT. So there could be ways that you could start to think about how you are distributing caseloads, how you are advocating for reimbursement, and how you are addressing the intensity of service needs that people have just by looking at the data. Okay. I'm going to move on now to some tips for tracking time and funding resources. And we're almost to our break. Because each of your agencies that are a part of the Academy have a very different makeup in terms of the number of programs you have, the number of people you're serving, who is funding your programs right now, thinking about how to track funding sources and doing this in one presentation was a little complicated. So right now I'm presenting some of the basics of ways that you can think about tracking your staff time, and then ways that you can think about tracking funding sources, and thinking about, how are you tracking funding sources by staff and by client, and by programs, and then thinking about, are you braiding funding sources together to serve the same people or to cover the same staff members' time? So the next two slides I have are going to present just a few of the basic items, but I do want to encourage you, please, to use the chat to share what you are doing currently or what questions are coming up, what's a sticky issue for you, and then we will open it up to allow anyone to come off mute if you want to share what you're doing or what challenges you're facing related to tracking funding sources. So in our documentation training, we talked about, that it's not required that you have a start and an end time in your progress notes, but that it can be helpful when you're wanting to track how long staff are spending with each client, and to get a sense of how staff time is spent overall, and to be able to tally up the number of total hours that are being spent with each client each month, as well as the total number of visits with each client each month. This will help you again in quality improvement to think about how you are using your resources and how staff are using their time, and ways that you can support staff, and also what are the needs of each client. And as I mentioned earlier, you can then think about reimbursement rates and do they cover the total staff time being spent. One other way you can do this, though, is by having a short-term staff time study and then extrapolating what you find, using the findings from that time study to then make assumptions or predictions about how staff are using their time overall. If you are interested in doing a staff time study, I think it's really important that you talk to staff about the reasons why you are doing it, to be really clear that it's not in any way about policing how they are using their time, or that it's not about distrust that they're not doing their jobs. But I think it would be important to brainstorm with staff, why it would be important to see how they are spending their time, so that you can advocate for better funding, and so that you can understand what supports they might need. If no staff are having time to take a lunch and everyone is eating in their car while they're driving to and from every appointment and don't get a minute to breathe because they are on their phone while driving to the next client, talking to another client while eating, and that's their average every day, you'll want to know that. You want to know that so that you can support staff and prevent burnout and turnover. So a time study is typically a 2-week period, or you can spread it across more staff and do it for a week. And it can be done on paper or it can be done electronically, but you're wanting to understand how staff are spending their time in terms of, are they working face to face with clients? Are they, doing something on behalf of a client, but the client isn't present? Is it over the phone or email? Location, activity, and then what service is being provided, because this will help you to think through as you're moving towards time studies, it'll help you to, or as you're moving towards tracking funding sources, it'll help you to see which services are covered under which funding source and what percent of staff time is being used for which funding source. That'll help you to then estimate and extrapolate so that you can say, 30% of this program's expenses are going to be covered by this funding source. And then other 25% is going to be covered by grants because that is their administrative time and their documentation time. And then the remainder is covered by managed care plan reimbursement for all the services that they are contracted to provide. We have gotten guidance that because there aren't yet regulations around what you can and cannot do there is guidance, but not regulation clarity in terms of braiding versus blending funding. That as you're thinking about tracking staff time and tracking funding sources, it's advised that you're thinking about it in terms of braiding. So having proof that you could always unbraid. And what I mean by that is that you can say this staff's time, these activities went to this funding source, and these activities went to this funding source. And if there's ever a gray area where both funding sources say they could cover something, then you're ensuring that only one of those sources is covering for that staff member's time. So you may then focus on the 12 out of 13 services that one fund can cover and make sure that they're not both paying for the same staff member. So a time study can help you to get at that level of detail in a way that's provides you with documentation should you ever need it to say you did due diligence, and also helps to demonstrate that that you are working on understanding and ensuring that you're not double dipping. If you are serving clients where they are only receiving services that are funded by community supports, then this will be obviously the easiest for you to then track your funding sources. If services funding comes from only one source and housing funding comes from another, but that's not the reality for most programs. And so I want to open it up to all of you to hear what you are doing right now as you are, assigning clients to multiple programs. Maybe they're assigned to a HUD funded program and also now being assigned to community supports. How are you tracking that? And are you using the managed care plan identifiers that they are sending you to, are you building out a new program for community supports, or are you simply adding tags to your existing client data files to be able to say that there is a new funder? Okay, so I would say if you then have, when you do start with a community supports contract, if there are any existing contracts that are used to cover your staff time, what you'll want to think through is how are you enhancing your services by offering community supports if you're providing community supports to people you were already serving, and see that reimbursement is going towards the enhancement of services. So if it means that it is helping to cover staff time documenting and staff time pulling reports and working on quality improvement, or if it makes it possible for you to lower your caseload sizes to provide better quality care, all of those things you could then think about if someone is enrolled in, if their services are being funded by multiple programs. Great, thank you, Jonathan. I really appreciate you both chiming in. And for those of you that are just listening and taking it in, feel free to share feedback or any questions in the survey after today's session as well. Our case management software allows staff to select each program label for each progress note. That is awesome. Amy, I'm curious if that is confusing for staff, or what type of training support you offer so that they know which program to select. Yeah.
Yes, it's sometimes confusing to staff. So there's the system, any software system is only as good as the data that people are entering. So yeah, that's an ongoing challenge.
Thank you for sharing. And Jonathan asks, what software do you use, Amy?
We're using Apricot 360 from Social Solutions.
Okay, thank you. Yes, I do want to say that I'm asked a lot about recommending softwares, and CSH is not able to recommend softwares, largely because we all have come from different service systems and have used different softwares, but aren't currently using them right now. So it's really helpful for those of you that are right now using these softwares. If you have one you like, please feel free to share it with the group, put it in the chat. I want to make sure that everyone gets as much as they can from the peer share out and learning as well. Okay. We're going to take a quick break. Thank you, Tanisha, for sharing. Also doing the same. So we'll break until, we'll come back just after 2:10. And the next I'm going to be talking about is the data that you'll be sharing out if you're a community supports provider. What's required to share out to managed care plans. So let's break for a few minutes, have a little stretch break, and then we'll come back for our final section. Hey, welcome back. Okay, our final section today is on the data and reports that will be sent from providers to partners and funders. So we'll focus first on the community supports monthly data reports that community supports providers will be required to share to managed care plans. So the file is called a community supports provider return transmission file. And this is included in that same community supports member information file sharing guidance that was just updated in April of 2023. So Ambrosia had shared the link with us earlier. And if you scroll down to about the middle of the document, it starts out talking about what managed care plans have to share to you, community supports providers, and then the second half is what you have to share back with them. So these community supports provider return transmission files, they have to be using the most timely and accurate data that you have available, and they are required to be submitted monthly. Managed care plans are not allowed to require that you submit them more often than monthly, but monthly is the requirement. There are some exceptions that could be made if a provider has, is able to mutually agree on scaling back the reporting requirements, and both parties agree to it. Then, similar to what I said earlier about the data that comes to you, if the data that you're sharing out, if you're able to agree with the managed care plan on doing something different, that's allowed. Managed care plans are asked to work together across their region. So if there are multiple managed care plans in your county, they are strongly encouraged, but not required, to establish regional agreements for the exchange. So a managed care plan might give you a file format or a template that they want you to fill in with the data. They are not required to use the same file format, but they're strongly encouraged to collaborate. So if you right now have contracts with multiple managed care plans and you're being asked to submit 4 different reports in 4 different ways, you can refer to this and request that they consider the strong encouragement from the Department of Healthcare Services to work regionally together so that it reduces administrative burden for you. I want to go through the elements that are required in the file. So it's fewer elements than the managed care plans are required to send to you, so that's good news. And some of it is the same data that the managed care plan sends to you, you'll send back. Okay, so the client identification number, the first and last name of the client, the community supports that you are providing, the start date of those community supports, and then the current status of member engagement. So DHCS provides codes. These are terms that they have said, or codes that are numbers that they have said, this number means this thing, this number means this. And you'll select, are you engaging with someone actively? Have you done outreach, but, aren't yet engaging with them? Are you discontinuing services with them? If you select discontinuation, you then have to also report on the service that you are discontinuing and the date that you are discontinuing that service. Also, the file also requires that you include the date of the file production. So when you pulled the file together and are sending it out, and then the provider return period. So what period you're reporting for. And again, you'll see the way that they structure their month, date, and year. They have very specific requirements around how that data needs to be structured. They are going to request that you include your provider name, so your agency name exactly as it is written on your contract. The National Provider Identification Number, so your NPI that you got, and your phone number. Like the other files that managed care plans send to you, those files that you send to managed care plans can be Excel-based workbooks, or they could be another file format that you agree upon with the managed care plan. So again, look at your contracts and determine, was there something that you agreed upon, or have they sent you a notification asking for your agreement to something other than an Excel workbook? And again, we want to, I just want to highlight that there are a number of exceptions that are written in the guidance. So it's important that you read through all of the guidance. I'm just highlighting some key pieces right here. But this is a monthly report that you would be required to send if you do contract with managed care plans for community supports. There are other reports if you are contracting for enhanced care management that you would need to send. And there's a much, much larger file called a MIF, or a member information file, that managed care plans send to ECM providers, enhanced care management providers. So there is a lot more in this online guidance. So again, this is just an overview. So managed care plans can allow that you share these files via email, but the state does say that it must be secure email. So it should be email that would meet HIPAA security standards, or you could submit it through a web-based portal that the managed care plan makes available to you, or SFTP transmission. I did check with one HMIS vendor and they said that SFTP transmission was possible. That's the limit of my knowledge of what SFTP transmission is, but it's a type of secure transmission of a file, and HMIS, you can turn that on. The COC can choose to make that available to agencies. So if you were doing all of this and pulling reports of this information from HMIS, there is a mechanism with at least some of the vendors to do this through SFTP transmission as well. Here I have included all of the links to the different data guidance that has come out so far, as well as the homepage that is the Enhanced Care Management and Community Supports homepage. If you're looking at the homepage and trying to find where all these documents are, you have to scroll down a little bit towards the end where it says key ECM and community supports documents. And there will be a lot of linked files. Many of them show when they have been last updated, because the department is regularly making updates to these as they get member feedback and provider feedback. So please save that website, and I hope that you're able to access all of these links. And thank you, Ambrosia, that you've been sharing them throughout the presentation. We're going to round out our session, but before we do, I'd like to hear any questions that you might have about the data elements that might be new for community supports providers, new requirements, or the systems that we talked about. Any questions for the group? Okay, so here's your reach, and it's your last reach for our academy. I'm so thankful that I've gotten to have this time with all of you, and it's bittersweet to have our final session. So I just want to encourage you, if you have not yet clicked on checking out the Path Cited grant application page, the Technical Assistance Marketplace portal, both of those, I'm encouraging you to explore those, dig into them, start on them. And then also, if you have not registered for your local Path Collaborative meetings, these are your local regional meetings. When you click on this link for the Path Collaborative, it will ask you to choose your region, and you'll select your county. And then you can sign up essentially to get notifications and invitations to be a part of these collaborative meetings. These are meetings that include anyone who is a community supports provider, anyone who's interested in becoming one or wants to learn more, or enhanced care management providers. It usually includes managed care plans and other provider networks. And it really is a hub for information sharing, for talking about technical assistance needs, for raising issues back up to the state that you want to be heard. So I'd strongly encourage you, if you're not already engaged with your Path Collaborative, sign up for those. Reach out to the team that is leading the Path Collaborative. You can have an individual phone call with them to learn what's already been talked about or what are in the plans. Different collaboratives are meeting at different frequencies. So this is an opportunity for you to then connect with whoever is leading that collaborative and find out how often they're meeting, why they're meeting that often, and what has been talked about so far, so that you're up to speed on what's happening in your region. All right, if you have an existing contract and an existing scope of work with the managed care plan, please, please, please review your contract for any data elements or data expectations and requirements. Review the provider manuals for the managed care plans that you're contracting with or that you're interested in contracting with. If you've been in conversation with a managed care plan and haven't yet signed a contract, you can ask them to share their provider manual so that you get a sense of what's expected of you even before signing a contract. Some have them online and anyone can access it, and others don't. And the last thing, I first just want to say a big thank you from our team to yours. This has been a tremendous group of people, all of you to work with. Your questions and your participation made this worth it. How engaged you've been, how active you've been in technical assistance. I'm just really thankful that you've taken the time and that you're working on these hard issues across our state, that you're working and fighting to get people housed and to support their wellness. So thank you from our entire team.